Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 107, LGBTQ plus and multiple sclerosis, the fight for inclusive and equitable care with Dr. William Conte. And now enjoy the interview. Hello, William. It's such a pleasure to have you on the show, and hi to lovely Chicago.
Hi, how are you?
Great. So it's really great to have you here on the show. And before we actually start with the interview, it would be lovely if you could introduce yourself to the audience so they know who is with me on the podcast today.
Great, thanks for having me. I'm Dr. William Conte. I'm a neuroimmunologist, currently practicing at a hospital system called Methodist Hospitals, which is right outside of Chicago, just over the border in Indiana. I'm also an assistant professor of neurology at Indiana University. I did my neuroimmunology training at the University of Chicago about 5 years ago at this point. Half of it was research, so I got a master's in public health sciences. Before that, I did my adult neurology residency at Loyola University Chicago and also did medical school at Loyola University. And, I see a lot of MS patients. I do research in many clinical trials for drug development and also do research in health equity.
Fantastic. That's quite a portfolio. Can you share a bit about your journey as neurologist specializing in MS and your experience as a member of the LGBTQ plus community?
Well, my story with neurology goes back to my college days, my university days. So I started doing some neuroscience research when I first started university in a lab, and I basically fell in love with it. It was an opportunity that I basically fell in my lap. I wasn't like seeking out neuroscience research. So basically fell in love with neuroscience, ended up, getting my degree in neuroscience. Then went to medical school. And then for residency selection, it just was a natural progression to go into neurology with the neuroscience background. As far as MS goes, I, fell in love with MS during my residency time just because I had a lot of patients in my clinic that had MS. And it was during a time, this was in 2013 to 2017. It was during a time where there's a lot of new drugs coming out. Ocrevus launched in my final year of residency. So it was just really fast paced stuff happening. I mean, I think there was like 3 different drug launches during those 4 years. So it was really cool that we could make a difference in patients' lives at that time.
Great. And what inspired you to advocate for the LGBTQ plus MS patients and focus on health disparities in this group?
So basically, I mean, I'm a gay man, and I really started advocating for it because I saw that there was an unmet need in this community. I mean, there's really not much research on this topic. There's really like 3 articles total on the experience of LGBTQ plus patients who have MS. So I was seeing an unmet need. I felt like I was on a platform to sort of advocate for this group. A lot of it's based on my own personal experiences, being a patient who's LGBTQ plus. And so I sort of identified a need here and wanted to advocate for this group. And thankfully, people are interested in hearing about it. And I think I could make a difference in that world.
Yes, it is quite important. And I think something like it should be like 10% of the people who belong to that group, maybe a little bit more. I don't know the numbers correctly, but that's quite a lot. And we should talk about it way more often. So do you think the LGBTQ plus MS community faces unique challenges that are often overlooked in healthcare?
Yeah, absolutely. So You said 10%, but it's actually in the US. I think the latest numbers are about 30%, and that includes people who are questioning their sexuality or gender identity. It's the latest numbers. I think it's as of 2 years ago. Obviously, it's hard to collect these numbers inherently. So the unique needs of this group is with that, especially with MS, it's multifaceted. First of all, as a minority group, it's a very interesting minority group because it's pretty much an invisible minority. Versus like racial ethnic groups, it's generally more a visible minority group. And what I mean by that is, I think depending on an individual situation as far as LGBTQ plus identity, it's hard to identify, other people in that community potentially. Whereas, a racial or ethnic minority, it's very obvious who's a member of that community. Obviously, the disclaimer is, there's different, groups in that community. Um, and so also LGBTQ plus people, we transcend multiple minority groups. So, I mean, we're represented in every single other minority group: racial, ethnic, socioeconomic status, disability. I mean, there's a huge laundry list of who's considered a minority these days, and LGBTQ plus people are in all of them. As far as MS patients go, um, the studies have shown that one thing, and I see this in my clinics sometimes, is that once diagnosed with MS, which is a chronic disease, research has shown that a lot of LGBTQ plus people withdraw from their LGBTQ plus community, and vice versa. LGBTQ plus, MS patients also don't feel welcome in MS support groups. So sort of a double whammy. And, as I'm sure is I'm sure all your listeners know, the social support is really, really important with MS. Um, in addition, it's actually, there's some more insidious problems that happen and this happens in all minority groups. But I think especially for LGBTQ plus people is something called minority stress theory, which is basically the theory that minority groups experience stress that initially start as external stressors, which could be like bullying, government policies, interpersonal discrimination, which then become internalized, which means like fear of rejection and internalized. One example is internalized homophobia, and then it changes people's behaviors and turns into a vicious cycle. And that ultimately has been studied to create health disparities amongst LGBTQ plus people. So we face higher levels of certain health conditions just due to this minority stress theory. And this happens with other minority groups as well. And as we know with MS patients who have other health problems do worse long term. So, it's very interesting to me. In addition, I think one of my research interests is the intersectionality of multiple minority groups. So in other disease states, intersectional identities actually has an even higher risk of minority stress. So an example of that would be like a Black, poor, trans woman, right? So
Mhm.
that's many minority groups right there, and those patients really do face a lot of health harms.
Okay, yeah, great. I mean, not great, but 30%, that's quite a lot, yes. And if you get out of all your groups, you don't get into the new one, and you are withdrawing from your old one. That doesn't sound good. So yes, thank you for that insight. How does the lack of the LGBTQ plus representation in MS research impact treatment options and outcomes?
So this is a big issue in my opinion, for a couple of reasons. One, just to state, really none of the phase 3 trials for MS therapies has ever included SOGI information, which stands for sexual orientation, gender identity information. Really none, at least that I'm aware of, and I've looked pretty much at them all. Even the newer ones like frexalimab, the BTK inhibitors, and they're still being designed to this day, they still don't include that information. And the important thing is when we want to look at participation in clinical trials, right? There's a big push to increase diversity in clinical trials. And this is a great opportunity to do that. Secondly, there's also a big push in clinical trials and also research overall for them that matter to study minority groups and look at differences in treatment outcomes, disease activity, etc. But we can't find that information out if we don't include that information. And it's a huge issue because like a lot of these pharmaceutical companies, nonprofits ask me to like, hey, can you probe our data to see if there's any information? And I'm like, well, what data? I mean, we don't have that information, and it's hard to probe it. There's just not really great ways of probing it if you don't collect anything. And sometimes we can get around explicit SOGI information by some sort of around the way methodologies, but like there's there's such basic information that's collected for the patients, their demographics in these trials. It's basically the demographics are age, sex, and racial status. That's pretty much
Mm.
it. The rest is like disease information, history, but it's very basic information that they collect.
And do you think people would answer that without any problems, or you think people would have issues answering that correctly?
Are you talking about the SOGI information?
Mhm.
Right. So you would have to set it up in a way, and this has been studied extensively. There's a lot of models for this. You have to set it up in a way that is open ended and allows the possibility of not responding to it, the
Of
option
course.
of that. You
Of
have
course.
to. I mean, and there's many models of ways to ask that information, which doesn't turn into this whole shindig. Um, at the very basic, it should be sex assigned at birth, right? That's the basic information, and that could be binary. Really, three options: male, female, or intersex. Right. So I mean, like even intersex patients, they're not capturing those in the clinical trials.
Mm.
And then so assigned sex at birth, gender identity, which could be the same as their sex assigned at birth, and one of those could be prefer not to answer, or also open ended, say like have a blank box there,
Mhm.
which creates a problem with coding eventually, but it doesn't take much effort to figure out the coding. Um, and then their sexual orientation, and there's many ways of asking that. Um, Generally, for healthcare professionals, I advocate for having super open-ended questionnaires about this. Don't have these checkbox. You just have like sexual orientation, blank line, gender identity, blank line, right? You know what I mean? So like that would be the best way in the databases to do it. And like I said, it could create a coding issue, but there's ways to get around that.
Okay, so you can put in whatever you feel like is appropriate for yourself. Yeah, got it. Um, how does medical mistrust affect LGBTQ plus MS patients, and what steps can be taken to build better doctor-patient relationships?
Yeah, I think the physician-patient relationship is super important in MS, which is, a lifelong chronic disease. And, unless I'm moving or the patient's moving, it's a long-term relationship that we form. So the trust goes both ways, and it's super important. And I think patients, regardless of sexual orientation or gender identity, feel this with their physician, or at least should, where I've got their back, and also not that they got my back, but more so like they trust my thought process within reason, and they're also open about sharing things that might affect their disease course or their general health. And I think I mean, this is speaking for myself mostly. I think, I'm a physician and a patient, and I'm also a gay man, and so I've had not had haven't had super bad experiences with physicians, but I think I could speak for most LGBTQ plus patients that we're constantly looking for threats, I guess, you know what I mean?
Yeah.
And, I think more so than, possibly other minority groups just because of the inherent invisibility that we face, is that, one, we're looking for validation, and ways to do that is creating a sort of an affirming environment in a healthcare setting, and there's many ways of doing that. And then two, also knowing that our physician is knowledgeable about our needs, and two, is knowledgeable about how to either learn those needs or learn about us. And there's not too much overt discrimination these days, I don't think, that at least I have heard of. What I think patients face is sort of this low level type of microaggressions,
Mm.
more so than overt discrimination, like refusal of treatment. It's more so this sort of microaggression, which then beneath the surface creates distrust.
Mhm. Yeah. And yeah, yep, yep, yep. I can imagine that, unfortunately. And yes, and the relationship is so important. I mean, I was driving 200 kilometers. What's that for you? That's well, a bit more than 100 miles to my neurologist for 13 years because I was living in a different city. But we really had such a good relationship. So, and now I moved back to my hometown, so I'm near now. Professor Tjalf Siemsen, I guess you know him. Um,
Mhm.
and yeah, having a good relationship is really important, and hopefully getting away from these microaggressions. So, does the mental health burden impact MS symptoms or progression in the LGBTQ plus community? What do you think?
Well, I mean, obviously, we just don't know this information, right? This is sort of the narrative that I've been talking about. Is we just don't have great outcome research with MS patients. Most of the research for MS LGBTQ plus patients is mostly about like the patient experience, of like their healthcare, services. I guess there hasn't been really any outcome based research, and that's what I want to start doing. And by what I mean outcome based, more about like, is there different treatment prescriptions, different disability progression, different outcomes like that. I suspect it just depends. Mental health in general is very heterogeneous. When someone says they're stressed or experiences stress, that's very different person to person, someone's experience of stress, for example, or a stressor, right? Someone can handle a stressor very differently than a different person. So it just sort of depends. And it's obviously hard to quantify on a population level. Um, I think it just depends. I do know that LGBTQ plus people as a whole experience worse mental health outcomes as a whole. Um, and that's all due to the minority stressors I'm talking about. The interesting thing is, one thing that protects a bit against minority stress is something called social support theory, which is the theory that supportive environments can protect against, you know, these discretions. So, in examples of that is, spousal, familial, social support. And also, one thing that's explicitly mentioned and studied is affirming healthcare. So a lot of neurologists, when I give lectures about this topic, they're like, "Oh, well, I don't, as a neurologist, provide gender affirming care. I don't do, LGBTQ plus health." And I say to that, "Well, you actually do, because it's it's not like a one time visit. They're with you for like a cut or cold at urgent care. It's a lifelong disease you're treating them for, and if you don't create an affirmative environment, you're only gonna, you know, continue the harm of minority stress. So we have an opportunity to combat that by providing good environments.
And what do you think? How can healthcare providers provide that nice, inclusive, welcoming environment for the community?
Well, it sort of depends on the comfort level of the physician, obviously, right? So simple things that I tell people to talk about, is one, just recognize, our minority status. Like, don't beat around the bush about it. Just ask, right? And let us say what we want to say. Um, as far as gender minorities, it's really important to ask the patient, what their pronouns or names are, because the name that they go by might be different from their legal name, depending on where their affirmation is. And I also counsel other HCPs, like you don't want for gender minorities, you don't want to say what's your preferred name or your preferred pronouns. It just is their pronoun, right? You don't ask me what my preferred name or pronoun is. It's just my name or pronoun. So that's an important distinction to make. And mistakes are going to happen, right? It can be really awkward depending on, the situation, but like stuff's awkward sometimes. Stop, acknowledge, apologize, and move on, right? And don't make the mistake again. Learn from it. And I think most of us LGBTQ plus people, we're not out there to, how do I say this? We're not out there to create a conflict with a physician. We just want to be like known for who we are. And so, we're not there to challenge them really. At least most of the time. I mean, I guess if mistakes keep happening, we probably would start challenging, but stuff happens. Even me. I mean, I'm a thought leader in this space and I make mistakes sometimes. Just make a
Yeah.
mistake, move on.
Yeah. And if you get a really meant sorry, I think most of the people don't have an issue with that. They're like, okay, yeah, thanks, great.
Yeah, one other thing I want to mention, so this is sort of like the basic level stuff. I mean, other things that are really good opportunities for HCPs, and also I'll talk about like even bigger players is one, you want to make sure the electronic medical record reflects the patient's name and pronouns. You want to, and also sexual orientation for that matter. Put a flag up somewhere, that'd be cool. That's more advanced. Sometimes institutions don't want to do that for whatever reason. I think from an even higher level, policy level, something for the pharmaceutical companies to do is have a same-sex couple in one of their patient brochures or on the website. Be provocative. Show a biracial same-sex couple with a child, right? Like, what I mean? Show the, commit to the representation. And and to that point, I mean, the pharma companies have been better in more recent years of actually using real patients in the brochures. So like that's been a plus, but like I don't think I've ever seen, an LGBTQ plus patient in any of the pamphlets or on the websites. And then obviously from a policy government level, that's a whole another can of worms depending on the country. So yeah, I mean, that's the span of how you can be more inclusive overall.
Yeah, lots of options, lots of place to improve. So what should the LGBTQ plus patients, MS patients look for when choosing a neurologist or healthcare provider to ensure they receive affirming care?
So this is a tricky question because I think with MS, there is an urgent need initially, newly diagnosed patients to get in with a proper MS specialist and also get started on high efficacy disease modifying therapy very quickly. I think in that regard, the most critical thing is getting in with a proper MS specialist first and foremost. I would suggest, because like I said earlier, I don't think there's too much overt discrimination these days. There's a lot of microaggressions that happen. I think you need to, you know, hear it out a little bit and sort of get an assessment of a practice for the long term, right? So, and this isn't unique to this type of topic. You need to feel comfortable with your neurologist or any kind of doctor for that standpoint. So you'll know pretty quickly, I think, if it's a good match. I think things to avoid is, this example that I said, very unflexible views of, they continuously, and this is an extreme example, it's more about pronouns and names for a trans patient, repeatedly getting confused on terminology or things like that. Like that would be a red flag for me. What else? Um, I mean, there's also like word of mouth. I think, and it depends on the environment. I think it's just a vibe. I think most patients these days, especially MS patients. I think MS patients are really, really resourceful most of the time. I think you'll know pretty easily. Um, the vibe and like it, but it can be challenging initially to know going into a practice if it's affirming or not. I just don't know of a great way of doing that other than checking it out.
And just to be curious, do you have patients who, let's say, come a long, long way to get especially to you because they are part of the LGBTQ plus community? Because I know this for my auntie who is a dentist and just a good dentist. People are afraid of dentists, so they are coming sometimes by flight because they prefer to go to her, especially.
Yeah, in my area is interesting because I'm like just south of Chicago, over the border in Indiana. So because I'm the only neuroimmunologist for a large, basically area. So unless the patient, so in the U.S., the way they insure, there's some state insurances depending on like income levels that end up happening, and with state insurance, you can't really cross the borders. So for those state patients, which actually is a large proportion of our patients, the next neuroimmunologist is probably 2.5 hours away
Wow.
from me. And then obviously, if they can get into Chicago, that's like 30 to 45 minutes, depending on the traffic. But most patients stay by me. So and there's probably 1 million people in the area that
Wow.
I serve. But because of my location and the distance to the next neuroimmunologist, I pull from a large, sort of multi, diverse population. So I would consider the immediate area to my area more suburban type of areas, maybe an argument for urban. And then I also pull from some quite rural areas. So I have a lot of patients that drive a long time to see me. I have a few patients that fly in, but not so much because they're seeing me in the sense of like we call them snowbirds. Like they have a summer home and a winter home kind of thing, but they like me, so they picked me as the neurologist instead of where their summer home's at, if you will,
Mhm.
or the winter home, I guess. Um, I do think because of the platform I do, and like I said, patients are pretty savvy these days. I do draw a lot of LGBTQ plus patients for a lot of autoimmune diseases to my clinic, just because they Google me and they see, um, and it's interesting stuff because of that.
Yeah. Okay. Thanks. Are there specific LGBTQ plus MS support groups or organizations that you recommend?
So, the problem with LGBTQ plus support groups, I actually think the best support groups are in-person support
Mhm.
groups for MS patients in general. Um, Obviously, an LGBTQ plus MS support group would be hard to do in a lot of areas, unless there's a large population in general. Not LGBTQ plus patient, but like you're not gonna be able to do an LGBTQ plus MS support group that well in a rural area, right? Just because there's not a lot of people in general for the space. So it's mostly limited to urban and suburban areas. I'm not aware of any actual local groups just quite yet, but there is the National MS Society has an online one that's well attended actually. I think the MSAA also has one, and this is in the US, obviously. I'm not sure, outside the US what that looks like, but I think it's super important for that sense of community.
Mhm.
For all MS patients, just to get little tidbits here and there from each other, and they see one how difficult it could be if they don't take the disease seriously, and two what works for those that do take it, have their difficulties. I actually think one of the secrets of MS success is the person's resilience and sort of positive outlook on life, right?
Yeah.
So if patients sort of succumb to their MS in the sense of, doom and gloom, this is taking over my life, rather than taking the mindset of, well, I have it. What am I gonna do about it? And, how am I gonna continue the rest of my life with this, demon in me? Instead of letting it succumb to that. And so that's really the secret with MS overall. We can give you the best DMT, but if you don't have the rest of the package, then, the best drugs, still gonna you're not gonna be great. And so I think you get that by seeing the other patients
Mhm.
doing it. I mean, there's a lot of that, seeing that's really what social support is seeing how everybody deals with their own issues in a certain way, and seeing that for yourself. So I'm getting sidetracked here, but so I think in person's better best. And but I think it needs to start online usually to grab the biggest group of people somehow. But there probably needs to be, so in-person support group in the big cities at least. I mean, I think that would be pretty easy. I probably could be better about spearheading that overall, but it's 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 important because, like I said earlier, the research has showed that it's a double whammy. The MS patients who are LGBTQ plus usually withdraw from their LGBTQ plus community, and then vice versa. They don't feel supported in the MS community.
Yeah. And for the listeners who are from smaller countries in Europe, yeah,
Right.
I guess please look online, because there it's probably not possible very often to find somebody to meet in person, or maybe do it once a year or so. But I guess online is way more easy, because we here in Germany is quite a large country, but still we have a lot of rural areas.
Yeah.
But all the other smaller countries with, let's say, smaller areas talking the same language. Um, it might be not so easy, but maybe check for the English speaking communities to get.
Yeah, and I'm sure the National MS Society community, they would be happy to have a European person there. I don't know if there's any restrictions for that. I doubt that there is, but I'm sure they'd be happy to hear the European perspective, although they're all English speaking, so
Of
hopefully.
course, yes. So, do you see already improvements in how the healthcare system addresses LGBTQ plus health disparities in MS, or not yet?
Not quite yet. So if you asked me a few years ago, I'd say, "Oh, the grass is getting greener," but, like, the recent, 2 to 3 years, especially for trans people, things, at least in the US, have gotten really bleak
Mm.
overall with healthcare policy, which is just increasing minority stress. So there's actually, new laws in a lot of our states that actually criminalize the physician if they provide gender affirming care, usually to trans youth. Um, and so, which is shocking that there's actually
Yeah,
laws that would
2025
positive
almost.
felony to the physician to do that. So that's kind of crazy. And so there's also other state policies in the US that are becoming more and more strict about stuff. So independent of the policies, one interesting thing about minority stress theory is even if you're not directly harmed, just hearing about harms or potential harms to you is treated as a threat, and you internalize that. So I think, especially for trans people, minority stress is the highest it's been in a while here in the US. I think that then, especially for the trans patients, and then even for non-trans patients who are LGBT, really LGB, um, I think hearing about that, it's like, oh, are we next?
Mhm.
For policy. So, I think overall things are not actually doing that well overall for minority stress theory. I do think, independent of the policies, I do think healthcare professionals are becoming more and more aware of how to interact with LGBTQ plus people, but people still have this whole anticipated discrimination fear within the healthcare system, whether it's, I mean, anticipated means more so you have a fear of it, not that it's a reality, but a fear of it then becomes their reality, about disclosing, their identity to a healthcare professional. And this is more so for the trans patients, but it still applies to LGBT patients. Yeah, so I don't know how to answer that. I think it actually looks pretty bleak right now here in the US,
Mhm.
when you take everything as a whole. Um, whether that then in the next 2 to 3 years translate to more direct health outcome issues, I'm not quite sure yet. I still think we're not at the fork in the road yet, but we're getting pretty close to that fork, if you will,
Mhm.
which is a shame because I think at an individual level, things are going pretty well as a whole. There's, a highest level of LGBTQ plus people, identifying as LGBTQ plus. A lot of those are the Q, which is queer questioning. So it's great. People, youth and the Gen Z um, generation is really questioning their gender identity and sexuality, and in a good way of, when I was a child, like there was no questioning. It was
Mhm.
just so very black and white. Now it's a little bit, more gray, which is the reality of it. It is sexuality and gender identity. It really truly is a spectrum.
Yeah, absolutely. Absolutely. Yes, and yeah, we just had a uh yeah, very strange request from your government to the European companies stopping their programs on this. And luckily, the French Prime Minister said, please don't get into our business. So maybe the community should get in contact with the European community. And see, no, sorry, it's not funny. I'm sorry. No, there's no way to make fun about that. No. Um, but I'm glad that a lot of physicians are getting in the right direction and hopefully stay reluctant to all that is coming. And yeah, I hope this will change to the positive again in a few years. And community is getting over it. And I totally know from a very close friend of mine who moved to Australia, maybe not because of direct discrimination, but because he feared or he felt so. And his boyfriend, they are not yet married, came with him, and I know that he is happy there. And for me, it's sad that he is living so far away, but I'm glad that he is happy, and I can totally see what the felt distress can make with people. So yeah.
Yeah, and that's sort of the crux of it is that it's a lot of it is the messaging, right? So even the policies, are they even going to be so an extreme example would be if you're a physician in one of these states that then I don't even know what the rules are in these states, but like provide some sort of gender affirmation to a trans youth. Would they even prosecute the physician, right? It's like that's a whole can of worms. And then prosecution is different than conviction, right? So, it's an interesting conundrum. A lot of this is really truly messaging and propaganda, and fear mongering, I think. But the potential could be very devastating on an individual level because the policies are there.
Mhm.
Um, but at the very least, it creates this huge fear of the possibilities. It's very scary stuff. Now, the other thing is, um, yeah. So I mean, there an extreme example would be the actual discrimination. But like I said earlier, a lot of these, I mean, this is microaggressions in public.
Yeah, yeah. Okay, so let's move on to the quickfire Q&A session. Complete the sentence. For me, multiple sclerosis is.
Fun, actually, and I want to say an additional thing about that. It's fun for me, but not for patients. I think it's actually fun for me because it's actually really interesting stuff. There's so much art to it rather than being a science these days, right? There's so many drugs within each class. You can kind of really customize it to the patient. It's actually a whole lot of fun trying to figure out what's best for the patient. Every single patient is completely different from each other. It really keeps me fresh.
Yeah. What development would you like to see in the field of multiple sclerosis in the next 5 years?
I think we really need a good remyelination therapy. In the next 5 years. And they've tried that a couple of times. It just hasn't worked out. I think mostly due to a study design
Mhm.
problem. And, I think remyelination, the problem is I think a lot of patients who have been disabled for 15, 20 years expect that they're going to get a drug that's going to fix them. I think it's more so kind of like a DMT in the sense that you have to give this remyelinating therapy during a relapse, for example, and then it actually then allows the repair after that relapse. I think that's part of the issue here. So I think
Okay.
that's the first step is a remyelinating therapy.
Yeah. So when you have the remyelination process, that it doesn't get destroyed right away. Yeah, we had that when we had neuroimmunology, neuropathology in the multiple sclerosis management master's program. Yeah.
Yeah, I also think not talk about therapies. We also need a good test for MS. You
The
made me
one
like
test, not the differential diagnosis, but the one test? That'd be
right, because right
lovely.
now it's just multiple pieces to the puzzle that then lead to a diagnosis. There's not like a test. We have that with some of the other demyelinating diseases like NMO, MOGAD, IgG4, but we don't really have that for MS quite yet.
Yeah. What advice would you give to the LGBTQ plus individuals who are newly diagnosed with MS?
Well, I would say the best advice is one, don't ignore the symptoms, right? So I think a lot of us are like, oh, it'll just get better. It's not. I mean, like, it's going to come back rearing its head. You got to take it seriously. I mean, inevitability. And as we know, I mean, newly diagnosed patients don't really know this, but it's all about prevention with this disease as of now. It's not great ways to fix things. So the best thing is get on a high efficacy therapy, get in with an MS, specific neurologist and MS specialist, and get on therapy quite quickly and make sure it's high efficacy if possible. Quickly. I think there's this critical window in which to treat it really effectively that has a long lasting effect long term.
Yeah. What is your message to healthcare professionals who want to improve care for LGBTQ plus patients, MS patients?
Yeah, my big thing, I think with everything in society, I think most of us just need to be curious about things, right? I think that's the best advice I can give an HCP. Like, everybody asks you like, oh, how could it be more inclusive, et cetera. Like, you don't have to like put flags up everywhere. I mean, that'd be nice, but just be curious, learn about how to treat patients, learn about how to take an organ inventory for a trans patient, learn how to screen, mental health problems, right? It's just being curious about our community is really important, and it really shows to the patient that they're in the right place. But you also don't want to be voyeuristic, if you know what I mean, and sort of ask too much
Mhm.
questions, right? So there's a balance. And so curious could be, asking the patients questions, learning more about them, but all curious could also be like take a course, go to a conference. There's always, LGBTQ plus sessions at most of the conferences now, thankfully. Not quite at Ectrums yet, but
Yeah, I just wanted to ask. Yeah.
yeah.
Okay, not yet.
Yeah, not quite at Extrams, but they're CMSC here in the US. I've been involved with for a few years now. There's been actually a session on it, but now it's mostly been merged into the underserved session. AAN, American Academy of Neurology, has I think 2 sessions involved with LGBTQ plus issues in neurology as a whole. Been involved in one of those. Those are the big ones, CMSC, ECTRIMS, and AAN for MS. But yeah, I'm not aware of ECTRIMS ever doing something. I wish they did. I'd be happy to help.
Yeah, yeah,
But
yeah.
yeah, and I think they're starting to. Last year they had a health equity session, so I think they're starting to think about it more. I probably could be more advocating for it too, but it's hard sometimes. So yeah, but just learning about stuff. There's a lot of online resources for HCPs to learn. A lot of them are free, really, very science based and important.
Okay. So last question, where can listeners find you or learn more about your work online?
Uh, well, you can Google me. I don't have a website, obviously. I mean, I have my clinic website. I'm in a bunch. I publish a lot, so I'm easily Googleable. I do stuff like this all the time. I'm on LinkedIn. You could find me pretty easily.
Yes, I see most of the stuff of you on LinkedIn. So, and I will put your LinkedIn profile into the show notes and then, of course, into the blog article. William, thank you very much. Thank you very much for bringing LGBTQ plus issues, important topics to the stage and helping the community to be seen. Oh, and a little one. We're all both a bit.
Okay,
Yeah, yeah, good timing. Finally at the end. Yeah, it's midnight here. So, yeah, thank you for everything and hope to meet you at one of the Actrums maybe in the future. Not this one,
great.
I guess, but maybe so the 2 ones after.
I'll be
One
there.
after.
Great. Thanks.
Okay.
Thanks for having me and giving me this platform.
Bye-bye.
Take care. Bye.
I hope you enjoyed the interview, and if you are part of the LGBTQ+ community, I really hope that you are feeling better now and that you feel a little bit more empowered and hopefully stay within your LGBTQ+ community and look for the new one, the MS community, because I think there's really no issue, and it's even more helpful to be part of a variety of communities. And as more social contacts you have, I think the better the life can be. So please stay as positive and active as possible, and see you next time. Bye.
Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.